a bit on TB preventive therapy as well as post-TB complications. So just make note as we go along the case, because there'll be a few thinking points at the end. And then we're going to go through the diagnostic algorithm for diagnosis of pulmonary TB in children and adolescents aged less than 15 years, followed by the diagnostic algorithm for diagnosis of extrapulmonary TB in the same age group. I'd also like to say that I've borrowed some of these slides from a presentation made by Professor Obimbo at our last KPA conference, and I thank her for always just being passionate about children with TB. So,
okay,
yes?
Can you put your slides in presentation mode?
On my side, they're on presentation mode.
Okay. Okay, I think just go ahead. We can see them. It's just that they're not in presentation mode.
Also, let me see. Hold on. Just let me see if I can. Any change? Hello, Phoebe, is there any change?
No, it's the same, but it's okay. You can see the main slide, so it's okay. I think just go ahead.
Sorry about that. I'm not sure what's happening. Okay, so this is a case of LWN who presented to us in January at the age of 4 months as a referral from Kenyatta National Hospital in Othaya. So the child presented with cough, fast breathing, and hotness of body, which had been present for 4 months, almost from the time he was born. At the age of 1 week, a positive gene expert, as well as a chronic cough. 2 weeks later, at the age of 3 weeks, the baby actually developed a cough and chest congestion. At the 6-week immunization visit, it was noted that the child had worsened and he was admitted for 8 days. But at that point, he was only managed for pneumonia with crystalline penicillin and gentamicin. He was well for a few days, but post-discharge, his symptoms recurred, and he was again admitted for another 8 days. But even during this second admission, the child was still just managed for bacterial pneumonia. It was not clear which antibiotics were given. At a third visit at the same facility, the child presented with similar symptoms, and they decided at that point to start the child on isoniazid preventive therapy only, which the baby took for the next 48 days. So by 3 months of age, the symptoms had progressed and there was continued fever, drenching night sweats, and the weight gain was noted to have stagnated. At this point, a chest x-ray was done, which I'll be able to share later, and they thought these findings were suggestive of TB. So note that the child's symptoms had actually started at 3 weeks of age. Anti-TBs were started at the age of 3 months. So this was done.
Marie, sorry, I'm sorry to interrupt. The slides are not moving.
Maybe can you project from your side?
Just a minute.
Sorry about that. Let me stop the share, because if they're not moving, that will bring confusion.
Okay, I think maybe try loading them again, see that whether it will work as I try to get Nelson to help.
Okay.
Mm-hmm.
Okay. Just give me a minute, Phoebe. I think I have multiple presentations on, and I think that could be the problem. Let me just close some down and then revert.
Hi, Anne-Marie. Yeah. Hello, Dr. Anne-Marie. Can you hear me?
Yes, I can. I can hear you.
Yeah. Can you see my slides?
Yes, I can.
Okay, so we move them for you. You can just go ahead. You tell us.
Okay. Okay. So just go back one slide, Phoebe. I see where I was. Yes, so go ahead to the physical findings, which I then summarized on the next slide. So of note is that the child on presentation was febrile. Next slide, Phoebe. He was febrile. He had a weight of 4.79 at admission, despite having been born at a quite good birth weight of 3.5 kilos. And you can see his vitals. He had low saturations on room air at less than 90%, which went up to 93% on 1 liter of oxygen. And the main findings were in the respiratory system, where the child was noted to be in respiratory distress with flaring of Alanesi, lower chest wall indrawing, good air entry bilaterally, but had a persistent wheeze that was asymmetrical and low-pitched. And this wheeze was more noted on the right. And this is important because children with TB may present with a wheeze. And this wheeze tends to be asymmetrical if you contrast it with the wheeze that you get, for example, in bronchiolitis, where many of the small airways are affected. Because the wheeze in TB is due to extra bronchioles, so compression of the large airways from the outside. The other systems were essentially normal. Next slide. So the baby, this is the X-ray I was talking about that had been done earlier. And if we look at the X-ray in November, during the treatment for the first episode of TB, I think what I encourage, registrars and even students to do is look at a lot of X-rays for children so that at the very least, you know what a normal X-ray looks like. So if you look at that X-ray that is depicted on the left, to my left, done on the 12th of November last year, you can appreciate that on the right side, we cannot see that cardiac silhouette properly because there appears to be some consolidation of the nodes of the lobes just behind that part of the heart, as well as hilar adenopathy. If you're able to zoom in and look at the trachea, you can see that there is narrowing of that right main bronchus just after the bifurcation. And then the child received crystalline penicillin and gentamicin. Note that some aminoglycosides do have some action against TB. So the child can have some clinical improvement, but that clinical improvement will not be lasting. And you can see then what the X-ray looked like in December when he was eventually started on TB treatment. Next slide, please. So these are the child CT scans done in Kenyatta. I hope it's clear from this slide that I picked, but even the radiologist commented that there was notable right perihilar and peribronchiovascular consolidation. So the pathology on the right continued with notable right mediastinal adenopathy, which I think is more visible in these lower slides, like from the fourth frame, yeah, from the top. And there was also left upper lobe subsegmental consolidation and atelectasis, and there were already bronchiectatic changes. So as a result of delaying this child's treatment almost 3 months, you can see how advanced the disease became. Next slide. So we did agree with the diagnosis of pulmonary tuberculosis, and a plan was made around how the child would be fed and oxygen therapy would be administered. He was also started on augmentin and azithromycin because it was felt that even a secondary bacterial infection could have exacerbated his symptoms. We also screened the child for rickets because he had clinical signs of rickets. A CSF was done because it was felt that with this extent of disease in such a young child, the possibility of extra pulmonary TB was possible. And what we fear most is TBM because we have poor outcomes, particularly in children who are not immunocompromised. The child was also started on steroids, which are indicated in all forms of severe pulmonary disease. And we planned for a pulmonologist review. Next slide. So this baby had a fairly stormy course in the ward and actually ended up being with us for almost 2.5 months. So initially did well, but on day 10 again began to spike fevers, which persisted. An examination on day 13 revealed fever with respiratory distress. The bronchial breath sounds were now present, and there was a wheeze being auscultated, more notable on the right. At some point, it was even felt that there was generalized wheeze and salbutamol was prescribed, which the pulmonologist later stopped. I think we were just really wondering what we could do to improve this child's clinical condition, and it was a bit frustrating to follow through his treatment. His oxygen requirements also increased. On day 21 of admission, we noted that there was a swelling in the neck, and we palpated a node in the right anterior cervical triangle. It was quite large, about 2 by 2 by 2, which is quite big on the small neck of this baby who's barely 3 months old. It had limited mobility. There were no changes in the overlying skin. When the patient was taken for excisional biopsy, they found a 4 by 5 cystic mass lying deep within the two heads of the sternocleidomastoid muscle that ruptured during dissection, discharging the cheesy yellow fluid with solid particles. Samples taken for histopathology revealed the typical caseating necrosis of tuberculosis, meaning that despite our treatment, disease seemed to be advancing in the baby. Next slide, please. So on day 53, Professor Obimbo reviewed this child. She agreed with the diagnosis of TB, complicated by severe left bronchus compression with hilar adenopathy and a miliary and extrapulmonary picture as well. It was noted that there had been initial improvement during the intensive phase of treatment and some radiological improvement early in the year. And the child's father had improved, so we were not suspecting multi-drug resistant tuberculosis. It was also noted that early in the year, the child had a severe pneumonia that caused a new insult to the lungs. And we had actually not been very prudent in just looking at how long we had used the steroids, because usually we start to wean the steroids when you're seeing a clinical response. So when the baby deteriorated, we went on with the steroids for a bit too long, which was felt to have contributed to the regression in the respiratory function and caused possible iatrogenic immune suppression. And again, there was that persistent wheeze, asymmetrical and low-pitched head beta on the right, and a decision was then made to revert to the intensive phase of therapy, 4 drugs for 2 months, ensuring that we were correctly dosing them. And then to look at that material that had been taken for histology, stop the nebulization, and after 2 weeks of treatment, repeat the chest X-ray and ensure that we are actually documenting resolution. We were also doing BGAs weekly, monitoring the child's temperature daily and weighing him every 4-5 days to gauge his response to treatment. And I'm happy to report after we restarted this regimen of restarting his whole treatment again, the child did well, started to gain weight, fever resolved, oxygen requirements reduced, and we actually discharged him about 2 weeks ago after 2.5 months in hospital. Next slide. So this case illustrates very well, I think, places where we failed a bit in terms of making a diagnosis. So this is how that algorithm looks, and I'll just take us through the algorithm step by step. Next slide, please. So one thing to note is that a diagnosis of TB in a child is a clinical diagnosis. So first of all, you have to have a very high index of suspicion. Please do not rely on microbiological diagnosis. So if we go through that slide, it says, does the child have presence of any 2 or more of the following symptoms which are suggestive of TB? So cough, which we say 2 weeks, but really any duration, because this was a child who had history of contact, persistent fever or night sweats, weight loss or poor weight gain, meaning you'd need to look at that child's growth chart and see which centile is this child starting on at birth. Are they continuing to grow along the same centile? What is that growth curve looking like? And then we have this very non-specific symptom called lethargy, or reduced playfulness, or reduced activity in the child, because generally we expect a well child to be active. So this is really just telling you that this is a sick child. And then inquire for positive contact or history of contact with a person having either a chronic cough or on treatment for tuberculosis. And just think about this baby LM, and did he fit this criteria? Was there justification even quite early on to have been thinking about tuberculosis? Then after looking at the clinical symptoms, you come to the clinical signs. So on physical exam, does the child have any of the following? An abnormal respiratory exam, and that could be, is the child tachypnic for age and the weight bands are there in the basic pediatric protocol? Are there signs of distress such as flaring and lower chest wall in drawing? Can you hear a wheeze or crepitations, or are your findings asymmetrical, suggesting that there is some localized pathology? And is the oxygen saturation less than 95%, or is the child cyanotic? Together with fever, as we have said, and really just looking at the growth curve. So if you have two or more of those first four, the cough, the fever, the weight loss, and the reduced playfulness, together with any abnormal respiratory findings, then already you're thinking this is probable or presumptive tuberculosis. And the next step is, are there investigations in your facility available to check for TB? Next slide, please. So following on the algorithm, so you can either have investigations available. So usually that is at least a chest X-ray. Rarely these days do we have the tuberculin skin test available. And then of course, get all means of getting that microbiological diagnosis and confirming it. You know, it is always good to do that. But remember that especially when you're having pulmonary TB, the children's disease sits inside the nodes. So it is not in the lung parenchyma. You will not see cavitation. So even when you get a sputum sample, it is possibacillary disease, and you may not actually get a positive gene expert. In fact, when we get positive gene experts, we know that child is basically teeming with tuberculosis, and we think it's probably even a miliary picture. So, but get your samples. It could be an induced sputum. It could be a gastric lavage sample. It could be, like in this child, the node that we excised and you take for histology, that can also be subjected to gene expert. However, you look at the chest X-ray, and I'll just talk about that a bit more. So the chest X-ray should just tell you if you have any abnormal findings on the chest X-ray, then that should qualify you for that second bit that we talked about, abnormal radiological findings. So again, it brings you to that box. You've done your chest X-ray, your gene expert is negative or it is not done. So you come to a clinical diagnosis where again, you're talking about two or more of the following symptoms: the cough, the fever, the weight loss, together with fatigue or reduced playfulness or reduced activity, plus any one of the following. So is there history of contact with a person within the last year? Because remember, for children, a lot of them will get active TB within that first year of life, but even up to 5 years after the contact is when the child may be becoming symptomatic, depending possibly on their immune status and the bacterial load of the original infection. Are you having an abnormal respiratory exam? And I think we've already described what that is. Are there any abnormalities on the chest X-ray? And lastly, do you have a positive MAN2 or interferon gamma release assay where that is available? So that last point of MAN2 or interferon gamma release assay, those are signs of latent tuberculosis. But combined with all these other signs of active TB, if you have two of those above, plus any one of the following, make a clinical diagnosis of TB, start TB treatment. So what is the message here? TB diagnosis in children is clinical. You will get it through your history and your physical examination. Just with a chest radiograph, that is enough for you to make a diagnosis. So please do not allow availability of gene expert or its lack of availability to actually delay diagnosis. So in the rarer instances where we do get a positive gene expert, then of course you start treatment. But like I tell you, when we see those children where even like this is a very sick child with a very high mycobacterial load. Next slide, please. So just to help clinicians to be able to read X-rays well, I would urge you to just download this free resource by the World Health Organization at the Union. So it is a diagnostic chest X-ray atlas for tuberculosis in children. The last edition was a very old one, but there's a new edition released in 2022. It is very easy reading. And it just takes you through how to diagnose TB from the clinical symptoms to how to look at a chest X-ray, to look at the measures of quality, and even how to interpret it. So a very useful resource for clinicians. I urge you to download it. So that is one of the films that is in that particular book. You can see a left pleural effusion. You can see right perihilar adenopathy. I don't know whether that is clear. You see the way that mediastinum is just looking wide. That should not really be there in a child who's over a year, and there's airway compression. Next slide, please. At this point, I was hoping the previous speaker would have spoken because we're just having a very high burden of TB. This is another child we were managing in the ward at the same time who presented with miliary TB. Again, there was positive history of exposure, but delayed treatment. So you can see just how bad those x-rays can get. Yeah. Next slide, please. So now we are moving to the diagnosis of extrapulmonary tuberculosis. This is just an excerpt from that pediatric guideline. Next slide, so that we look at it in a bit more detail. So now just note that for extrapulmonary tuberculosis, we are still talking about the same symptoms, except that now you have to relate them with the organ involved. So they will be, rather than a cough, you will have a symptom presenting in the relevant organ. You will still have fever or night sweats. You will have poor growth of the child and reduced activity, together with any of the following, which could be the presenting sign in the relevant organ. And that particular chapter even goes ahead to show you what is the site of the extrapulmonary tuberculosis and which are the signs and symptoms by affected site and which investigations should you carry out. So for example, if it is CNS disease, you're talking about having CNS symptoms, convulsions, a loss of consciousness. The sample in question then will be the CSF. The imaging that you're doing is possibly a head CT scan. So this table, again, I will not go through it line by line because it is available in the guidelines, but just to point out that if you're suspecting extrapulmonary tuberculosis, it will be that same general presentation with the general symptoms, but then relate the signs that you're seeing in the child to the organ that you think is affected, again, having a very high index of suspicion. We are now able to do gene expert on CSFs, but again, it will also show you a very high protein. It will show you changes on the CT scan, for example, a new onset hydrocephalus because of that thick meningeal exudate. And where you're not sure, please do refer these children. Next slide. So the presentation is actually done because diagnosis in children is as simple as that. Yeah. So just for us to go back and review and think about the case that I presented, why was there a delay in diagnosis? So if this history had been taken well at that first contact, was the clinician actually aware that the child's father was under TB treatment? Or is it the usual thing, you turn up for the 6-week visit, a bit of cough and fever, and we assume, oh, these are the usual childhood infections, either a bronchiolitis or a pneumonia. So just taking a good history would have provided the first clue. Was there delay in microbiological diagnosis, and did this make the clinicians feel that they could not start TB treatment? Again, I emphasize that diagnosis in children is largely clinical, as we have seen. And do we have knowledge of this very simple algorithm? Perhaps it is something that we need to just print out from the guidelines and have as an easy visual in our outpatient facilities. So at the third visit, when they made a decision to start TB preventive therapy, for a child who had already received treatment twice for pneumonia, and we have said drugs like aminoglycosides will have some effect against TB, so there can be some clinical resolution. Was that the time maybe to seriously think about TB? And then thinking about this baby, what were the consequences of late diagnosis? We saw how advanced his disease was, leading to a very prolonged hospitalization. And I'm sure my colleague, Dr. Andrew, is going to talk about the effects on the lungs. But just to say, if when it is happening to a baby from the age of 3 weeks, what do we expect for this child's lung function going forward? So really thinking about what were our particular learning points as we went through this particular case. So I'll stop my presentation there and maybe I can take questions at the end. Thank you, Phoebe. I don't think I have another slide. My last slide was actually a call to action. Maybe you can just put it there to tell us that with just good clinical skills, we can actually win the war against tuberculosis. Asanteni.
Thank you, Dr. Anne-Marie. That was an excellent presentation. I think please post your questions for Dr. Anne-Marie on the Q&A. So we'll just move next to the next presenter in view of time. So we have Mr. Ayabe. We have Mr. Ayabe from the TB Management Center at Kenyatta National Hospital. And Mr. Ayabe will be taking us through the burden of TB. Yeah. So bear with us as we load his slide. Please go ahead.
Okay, welcome.
Yeah.
Now, thank you so much. So we just wanted to see the overview of the TB burden in the whole world. So the global estimate for people who fell ill with TB in 2022 was 10.6 million. People who are newly diagnosed with TB and notified in 2022 was 7.5 million. There was a rebound above the pre-COVID level, 7.1 million in 2019, 16% above the level of 2021, and 28% above the level of 2020. And the highest number for a single year since WHO started global TB monitoring in the mid-1990s. As you can see here, this is the drug-sensitive TB notified in 2023. There were 97, 126 in Kenya. And then the drug-resistant TB was 706. And then the pediatric case finding in 2023, 12,884. And the outcomes for TB in 2022, there was a cure rate of 77%, which was achieved. That was an increase from somewhere. So there was some work which was done there. So there is a treatment success rate of 88%. And the sector contribution, you can see private sector 19.6%. And the main one is the public, which was giving us at least the other percentage, which is over 89 point something percent. Yeah? And then you can see the contacts on TPT in 2023. Contacts listed was 55,324. And then those who were initiated on TPT was 45,398. And then the HIV testing in 2023, there was an increase of 98.1%. And then the drug resistant TB surveillance for previously treated cases in 2023 was 60%, and there was a decrease from achieved from 60%. Yeah? And then you can see here the trend of TB from the year 2011 to the year 2023. You can see in 2011 there were 99 cases, 99,159 cases. 2012 there was a decrease to 89,332. 2013 89,333, and then 2014 you can see 81,447. And then 2015, there was 81,518. And 2016, now it started to rise up from 75, and then 2017, 85, 96. And then also there was a decline. And this one depends on the strategies from partners and the MOH and the National TB Program. But you can see still, TB is still going up. It goes down and it goes up. And this is a question that we are asking ourselves, why the rise and fall of the cases in Kenya. Now, the treatment success rate is 88%. The country experienced an increase in treatment success rate from 86 in 2011. Majority of the counties posted an increase in this indicator. A cure rate of 77%, and the country experienced an increase in the cure rate from 76% in 2011. Majority of the counties posted an increase in this indicator. Now, here there is also the death rate, because these are some of the indicators that will tell and inform our National TB Program and the MOH on what we are doing. You can see the death rate is at 6%, of which we expected this was at 6% in 2011, and this is expected to be even less than 3%. And then 5% lost to follow-up. This is a very high in the country. So we still have a loss to follow-up of 5% by the year 2011. And then some of the patients were failing. And these are the failures which they fail to convert to culture negative, which is 1%. And this one will move to category 4, which is the drug-resistant TB. So that 1% of all the cases is a high number. We cannot see just 1% as a small number. So in 2023 cases, there was a 7 or 6% decrease. So this of the drug-resistant TB cases, and the case finding from 756 cases reported compared to 2022. And you can see for the drug-resistant TB, 2017 for the adults and the children, 21 children, 517 adults, 2017, 2018, 21 children, 684, 21 children, 684 adults, and then 14 children, 2019, and 688 adults. In the year 2020, we saw a big increase, 24 children and 933 adults, and 2021, 20 and 784, 2022, 29 children, 729 adults, and 2023, 22 and 684. At least this one you can observe that the more the number of adults coming with PRTP, also the increase in the number of children because of the contacts in that area. And then drug-resistant TB treatment success rate of 87% in that, which is was 81% in 2020, and then 72% cure rate, and the country experienced an increase in cure rate for drug-resistant TB patients from 67% in 2020. So there is a lot of work which has been done for the drug-resistant TB, including capacity building and resource mobilization from the Ministry of Health, the National TB Program, and all the partners. And death rate for this case was 10.5% in the year 2020. So that was an increase of 11%. And then now the loss to follow-up is 4% for the drug-resistant TB, which is a high notification for loss to follow-up. So we don't know where these patients go to, but by then we knew that most of the patients who were treated for drug-resistant TB were people who are migrating from Somalia, so they came easily and maybe they left for the country. And Kakuma was also closed as a refugee camp, and that is where we saw that loss to follow-up. Those ones who are not evaluated, the country experienced a decline in not evaluated rate from 1% in 2020. So that decline in loss to evaluation is a good indicator because it means that you are monitoring most of your patients well. Now you can see Nairobi case finding in the year 2020 to 2023, 2020, 9,407, 2021, 10,570, 2022, 12,114, and 2023, 13,048. What does it mean? TB is still within our communities and most of the populations. And as these are the ones who have been picked, it means that we are also, there was a study which was done on surveillance of TB in 2016. It was saying that there is a case of 16% which we lose in case finding. So if you can see 9437 and 13048, 2023, there are some interventions which we are doing to make sure that we are doing some active case finding and also using the radiological perspective to diagnose TB early in adults and children. And the way Dr. Anne-Marie was telling us on how to have high index of suspicion for children. Now we can see also the contribution per county in Nairobi, per sub-county. Already you can see 2022, we are comparing from 2022 and 2023. So Dagoretti reported 10, 12, 20, 2022 and 2023, 1197. Embakasi is the leading in Nairobi. You can see 2022, 2813, and 2023, 2929. Kamukunji, this is the CBD, 943 and 874. Kasarani, 838, 2022, and 875, 2023. And then Lamata Kibra, which is also where Kenyatta is also, I think, is the second most reporting cases because of the slums and the population within Kibra. And Embakasi, you can still compare those areas of Embakasi and those areas like Kayole and the other ones. So the slums are contributing to the high numbers. And Langata, you can see 668 and 729. Makadara, 457, 468. As the lifestyle of the people living in that area goes up, the cases of TB are bound to come down. But in the slums, because of housing, nutritional issues, and many other factors, you can see cases. Waraka, because of the Thika Road and the other areas, Kasarani and the contributing factor, 1318, 1479. Stare, 1427 and 1633. Westlands 680 and 836 in 2023. And then you can see also the drug sensitivity treatment outcomes in 2021 and 2023 in comparison. We have the cure rate, you can see 2021, 72%, and it remained at 72% in 2022. Treatment success rate, 2021, 84, and then it increased by 2022 to 88%. Close to follow-up, you were at 7% at 2021, and 2022 we came to 5%, and so there is a lot of activities which have been done to reduce that loss to follow-up, which is a good indicator, and we need to come down to even less than 3%. The death rate was 6% 2021, category 4 now coming up, and those ones now are the drug-resistant TB cases. It remained at 1%. And then we can see the drug-resistant case finding 2020, 2023, 2021, 15, 2021, 97, 2022, 82, and 2023, 83 cases. Now we can also see this is 2020, 2021 drug-resistant TB treatment outcomes. Cure rate was at 70%, 2020, and 2021, 6%. Treatment success rate 84, and then it came back to 82%. The death rate here was at 8%, and then it went to 11%. So there is a problem there, and some interventions are being done. Close to follow-up, 7%, and then it came back to 5% 2021. Now, I think that is the end of my presentation, and we will ask the questions later, and we will have some answers. Thank you.
Yeah. Thank you, Mr. Bay. That was a great presentation on where we are when it comes to TB. So we'll move to our next presentation. We have Dr. Samuel Njenga, who also works at the TB Management Center. And Dr. Njenga will be taking us through the diagnosis of TB in adults this time. Welcome, Dr. Njenga.
Thank you, Phoebe. And good afternoon, colleagues. We have just heard that we are not out of the woods with TB. You can see the burden. And just like we heard when we were talking about diagnosis in children, it's very important to make early diagnosis. So this is just a short presentation. Most of what is something that we know, but as we see the TB patients, we have an advantage. At the TB Management Center at Kenyatta, we have quite a number of referrals. So we are able to see what is happening when the TB patients interact with the healthcare system prior to the diagnosis of TB is made. So we want just to highlight what we think we should do, especially when we are trying to diagnose tuberculosis in adults. So next slide. So just like we do with all other patients, history taking for TB diagnosis is very important. And in this history taking, we need, first of all, to establish whether what we are dealing with are acute symptoms or chronic symptoms. Just like we had in the pediatric age group, we have found that most of the adults who will eventually be found to have TB will already have attended or have visited various private facilities or public facilities and be treated for pneumonia, community-acquired pneumonia. So whenever we have an opportunity to interact with a patient who seems to have symptoms that are suggestive of TB, in the case, for instance, of pulmonary TB, it's very important to know whether this visit is the first with such symptoms. Because the moment you realize that this is not the first time the patient is presenting with the same symptoms, that should make you start thinking, could this be something more than just a community-acquired pneumonia? Then, while doing the history taking, it's very important to understand, find out from the patient, is there a possibility that there was exposure have they been living with someone who may have had maybe pulmonary TB? Could they have been in a setup where someone else was treated for pulmonary TB? So you need to explore, is this patient before you, have they had an opportunity maybe to get exposed to TB? And related to that, it's important to understand the occupation of the client that you are attending to, because some occupations can predispose you or can put you in circumstances that you are likely to be exposed to TB. A simple and quick example is a healthcare worker. You need to establish, because sometimes when you are having a client, they may not volunteer the information that maybe they are a healthcare worker. They may not volunteer the information that maybe they are nurse attendants, that they have been taking care of a patient. So you need to establish that. And of course, the lifestyle. Then you need to establish the medical history. You may have an opportunity even to know that the person you are attending to may even have been treated for TB previously. So we have to delve into that. Then during history taking, the history taking process should be empathetic. And it should be more like a discussion with the patient or with the client, not interrogative. Because the tendency is when you are interrogative, some of the critical information that may help you know whether the patient is likely to have had TB, they may hold back that information. So as much as possible during history taking, it should be empathetic and more of a discussion with the client. Then look out also for nonverbal communication. Pointing, are they pointing to some part of the body? A patient may just be presenting with general symptoms, but there's a place that they are persistently pointing, maybe where the pain is, they are touching. So this should start preparing you to know even how you will be able to carry out your clinical examination. So by the end of history taking, you should be able to start answering the question, could I be dealing with pulmonary TB? If essentially the symptoms were respiratory symptoms, could this be a pulmonary TB? If the symptoms were not respiratory, they were in another system, could this be extrapulmonary TB? So that from the history taking, you should be able to start thinking in those directions. Next slide. So TB in adults. TB in adults, what are the symptoms? So we can say there are two sets of symptoms. They are the general symptoms. The general symptoms, they will apply for pulmonary TB, they will apply for extrapulmonary TB. So a patient with pulmonary TB, a patient with extrapulmonary TB will have malaise, will have loss of appetite, will have weight loss, fevers, night sweats, and pains. Okay? But sometimes when we are seeing clients, a client may emphasize one of the symptoms, but if you don't ask about the others, they may not volunteer that information. So we need to explore when they are telling you about the symptoms, just don't go by the immediate symptoms they tell you, explore whether they have other symptoms they are not telling you about, okay? Then there are the specific symptoms which are related to the part of the body or the system that could be involved. So if, for instance, someone is likely to be having TB meningitis, they will present with a headache. If it's a PTB, pulmonary TB, they will have a chest pain, they will have a cough. If they have TB peritonitis, they may present with abdominal swelling. They may present with ascites and so on. Okay, or they may complain of abdominal swelling, abdominal pain, and maybe neck swelling, voice changes. So voice changes, a patient may come with voice changes. Maybe you think very quickly, this is an ENT problem. The patient may be middle-aged, he is a smoker, but you start thinking in the direction of CA larynx, but it could be still a TB. So think about all those things. Then a patient may come with reduced vision. You can also have ocular TB. So when a patient complains of reduced vision, don't just think of the usual suspects. You should also think TB. Then find out about the duration and the progression of the symptoms, and then the severity of the symptoms. When you, that's back. So when the patient is reporting the symptoms, you should also be able to establish, because eventually, even when you make a diagnosis of TB, you may also find you need to also manage another aspect of what the patient has. So you need to know what are the severity of symptoms, because if, for instance, you may finally make a diagnosis of TB of the spine, but the level of pain may be such that the quality of life for that patient is not good. So you need to address that aspect of the pain. Next. Next. Okay. So, sorry. Examination. When you are examining an adult that you suspect has TB, you need to start with, as usual, you need to start with the vital signs. Why? Because even a patient who has TB could still be having an acute problem, including acute community-acquired pneumonia. Sometimes you may even encounter a patient, you make a very good diagnosis of TB, you are able to diagnose the TB, but you don't also realize that on top of the TB, they have an acute community-acquired pneumonia. So you should be able to look at your vital signs and know that even before starting the TB treatment, is there another issue in the patient that you need to address? Then you need to do a general examination. So in TB, what will you be looking out for? You'll be looking out for things like wasting, looking out for anemia, looking out for malnutrition, jaundice, cyanosis, lymphadenopathy. You even look at the gait of the patient, because this patient coming with headache or back pain may already be having a gait that is showing the progress of the disease. So you need to look out for that in the general examination. Still, TB patients, sometimes a patient may not be improving on treatment, maybe because we are also not addressing some of the other issues that have been there. There could have been malnutrition, there could have been anemia. We need to address those issues too. And then you go to the systemic exam. So the systemic exam will be guided by what you have found from the symptoms. If you think you have pulmonary TB, then you do a respiratory examination. If you think you are dealing with TB of the abdomen, you will do an abdominal examination. And in the process of the examination, that is where now you start getting your differential diagnosis. You get your differential diagnosis. Even during examination, you can already start ruling out some of the differential diagnosis. And the examination finally is going to also help you to focus your investigations. Investigations including imaging, so that the moment you have made a decision you are suspecting TB, you will focus on, if it's extrapulmonary TB, you will focus on imaging that is relevant to that particular system that you suspect is involved. Next. Okay. Patients, you have a client. You have had an opportunity to listen to them, take their history. You have had an opportunity to do an examination, and you start suspecting TB, pulmonary TB or extrapulmonary TB. So for you as a clinician or as a healthcare worker, TB is now becoming a possible diagnosis in your client. So as you interact with this patient during examination, during history taking, it is the time also to start exploring what knowledge and what attitudes they would have towards TB. What do they know about TB? And whatever they know, do they require additional information that that you need to give them as a healthcare worker. You are private to some more information about TB. This is the opportunity also to start discussing with them, sharing with them any additional information. Most of our patients, they will not be alone. Most of our clients will come with members of the family. So this is an opportunity. Also, that interaction is an opportunity to start client and family education on TB. And then it's at this moment that also you start explaining to them what type of investigations they'll do. It's important also to explain to the patients why you are doing a particular investigation, what we expect to find in that investigation, and what will be the implications of the findings. And then at that moment, you need also to start discussing about treatment. And most likely, the client will even start asking you questions. So it's very important that we have a discussion with the patient or with the client and be able even to answer their questions. So this is the opportunity to create a consensus or consent or a partnership with the client. Because essentially for the data we have seen about success rate, about patients, the patients falling out of follow-up, all these issues, there are things that we can do as healthcare workers. The moment we are interacting with the patients, there's an interaction we can have, a type of interaction we can have with the patient to ensure that when they start the treatment, they will have there will be adherence, that they will be coming for their medication and so on. Then lastly, you need to create a reassurance. You need to empower the client and the family to be able to go through TB treatment. Okay, next. So TB diagnosis in adults. What are some of the investigations that we can do? Well, this what we have here is not exhaustive, but I tried to pick what can be available in most of our facilities, regardless of the level of the facility. So when diagnosing TB, you can do hematological investigations. And I think most of our facilities have that capacity. So even if you are not sure whether you are dealing with TB or not, it's very important that you carry out some hematological investigations. One of which is a full blood count. You can do an erythrocyte sedimentation rate. You can do a CRP. Then there are the radiological investigations, starting with the lowest, which is the X-ray. Then you can move on to the CT scan. Then you can move on to the MRI. What I would want to point out here is that sometimes we may find we are diagnosing TB, PTB, pulmonary TB with a CT scan. But if you look at the older X-rays of that same client, you find if the X-ray had maybe you had even consulted, talked to a radiologist, there was something in the X-ray that was indicative of or suggestive of TB. So sometimes we need to start with the simplest investigations and then exhaust the discussion. If you may not have very good capacity to interpret a chest X-ray, but there could be someone else. There are radiologists, so you can get the report or the feedback from a radiologist, so that if it is PTB, you don't have to diagnose PTB at the level of a CT scan because of even the issues of the cost. In our facility, sometimes we see a patient who is eventually diagnosed to have TB of the spine, but the diagnosis was made after an MRI. But if you look at the old X-rays that patient had taken, even 4 years ago, you find there was something indicative or suggestive of TB of the spine. Then we can also do microscopy. So microscopy is done whenever you do a ZN staining, Auramin staining, or histological staining, you use a microscope. And for microscopy, some of our facilities have microscope. So we are able to do ZN staining. And what we would encourage is that whenever you are suspecting TB, if that capacity is there, and most likely it is there, in most microbiology labs, there will be capacity to do a ZN staining. You can do it and do for TB, bright field microscopy. in some laboratories, they may have capacity to do fluorescent microscopy, and that's when we do the aluminum staining. So what we are saying is that let's make maximum use of the capacity, the microbiology capacity or the laboratory capacity we have in our facilities to make our diagnosis. Then there are bacteriological investigations. By bacteriological here, I mean mainly culture. Okay, culture for TB is not very routine, but there are special circumstances, and all those, the guidelines are there. The guidelines tell us when we need to do culture. So sometimes you may need to send a specimen for culture, and that is especially where you are not sure about drug sensitivity, and all that is in the guidelines. Then finally, the other group of investigations is the nucleic acid amplification tests. A good example is the GeneXpert. So nowadays, post-COVID, the capacity for GeneXpert has increased. So let's try to make good use of that capacity. Okay, next. So what would you find hematologically? Why I've selected hematological is because this is one of the simple tests these are some of the simple tests you can do almost at any facility. So whenever you have TB, there are very high chances that the ESR will be elevated. It will be above 20 millimeters per hour. It can go as high. It can go as high as even 130 millimeters per hour. And sometimes there is a relationship between the ESR and the duration of the symptoms. So it's very important that whenever you are investigating TB, you also do an ESR. Okay, now for blood count, you may also see lymphocytosis. Usually lymphocytosis of more than 40%. It doesn't mean that every patient who has TB has lymphocytosis, but do the test. Those are some of the things that will start suggesting to you that you could be dealing with TB. Then you will have also a picture of normocytic hypochromic anemia. It's actually a picture of anemia of chronic disease. Then CRP, where it is available, is a very common test nowadays that is done when a patient has any pneumonia. If you are treating a patient who has community-acquired pneumonia, an elevated CRP will go down as if they are responding to the antibiotics you are using. But if the CRP was elevated and it's not going down after even the antibiotics, the chances are that you are dealing with pulmonary TB. If it was you were treating a community-acquired pneumonia. Next. Okay, radiological. So usually the views that are done, especially in X-ray, we have a posterior anterior view. You can also do a lateral view and a rhodotic view. Okay, sometimes the radiologists, they prefer that you do a PA and also a lateral, so that they are able to see almost you're trying to get a three-dimensional view of the pulmonary cavity. Then in the chest X-ray, especially in adults, you will usually have upper lobe infiltrates. They could be in the right lobe, they could be in the left lobe. You can also see cavitation. You can also see a miliary pattern. You can also see mediastinal widening, and which is a sign of lymph node enlargement. You can also find a pleural effusion. In a spine X-ray, you can find early spondylodiscitis. So mainly what you will see is, if you compare the vertebrae, you look at the vertebrae, you look at the discs, you will notice a disc that doesn't look like the others. You will notice a vertebrae that doesn't look like the others. There could also be disc narrowing. So even if you're not sure, you can now consult. As long as you have seen there is something abnormal about that spine X-ray, about that chest X-ray, please consult. Then you can also do CT scan and MRI where it is it's necessary, because they have higher resolution. Next. So what are the specimens that we usually use when we are trying to diagnose TB in adults? So these are the specimens that we subject to microscopy, histology, bacteriology, and then nucleic acid amplification tests. So we can have sputum, we can have exudates, pus, CSF, pleural fluid, ascitic fluid. all that. The take-home message on that is that whenever you have a patient, especially a patient with a chronic disease, a patient who has been in and out of facilities, if you take a specimen, whether it's a biopsy, whether it's in gynecology, whether it's in surgery, please, let's try to look for TB. Sometimes we get surprised. As a specimen that no one was suspecting had TB, when subjected to ZN staining, auramine staining, or even gene expert is found to have TB. So whenever we take a specimen, whichever type of specimen, let us look for TB. Then we can also do culture, as we have said, but culture will take 2 to 8 weeks. And this is especially when we want to do drug sensitivity testing. Still, we can also do what we call RINE probe. This is also an example of a nucleic acid amplification test. That is, in 2 weeks, you are able to, once you do a culture, using, you can be able to establish within 2 weeks whether you are having TB, and also you can be able to see the genome and establish whether the TB that you have is responsive to the first line drugs or the second line drugs. Then lastly, I would gene expert. What I want to communicate here is that gene expert is quite available, and it's also good because gene expert can give us results in 2 to 6 hours. Depending on the protocols in the lab, it is possible to know whether you're having TB within 2 to 6 hours. So you don't need 24 hours, you don't need 48 hours to make a diagnosis of TB. So in conclusion, what I would want to say to us as healthcare workers, whenever you have a client, think of TB. Could you ask yourself, this be TB? Actually, even in the guidelines, there are guidelines on what we call active case search. They are actually, even in our patient departments, there's a tool that can be used for screening for TB. A few questions that you ask a patient and you are able to establish whether they are likely to have TB. So let's think TB, ask ourselves, with this patient I'm having, could they be having TB? You could be in a gynecological unit, you could be in an ENT unit, you could be in a surgical unit, but maybe what the problem that the patient seems to be presenting with, the underlying cause could be TB. So we take detailed and relevant history. Then you are also assess TB awareness of the client, give some client education, and destigmatization. That is, you see, this, it's also your opportunity as a healthcare worker to stop the stigma against patients who have TB. And sometimes even the stigma is with the patient themselves. So you need to reassure them that TB is treatable, and once someone is treated, complete their treatment, they'll be okay. Then examination should guide our investigations. So the aim of all this is early diagnosis, early treatment, and less morbidity and less economic burden. Treating TB is very expensive. So the longer we take before we diagnose TB, the more damage there will be to the organ involved, whether it's the lungs or any other organ in extrapulmonary TB. So it's very important that we do early diagnosis, early treatment, and therefore, eventually, it is possible to stop TB. Thank you.
Thank you very much, Dr. Njenga. So we move on to the next presentation, which will be on TB treatment. Yeah. So the presentation will be given by Agnes Muthe. Yeah, she's also a clinician who works at our TB Management Center. Let me just share your slides.
Good afternoon. Now that we have been able to go through the diagnosis of TB, this is the high time we look at the TB treatment. As we heard about on our TB burden, we found that our treatment success rate, or the patient that successfully complete treatment, are at 80%, and our cure rate was at 77%. We need to know how do we treat these patients, so that finally, all these patients that we are trying to look for during the diagnosis, we are able to treat them successfully, and that's the only way we are able to fight TB, since we'll be able to reduce the transmission. So we see as the patient preparation. This way now, after the patient has been diagnosed with TB, we need to still take a detailed clinical review. This way we ask about the previous history of TB treatment. This patient might have taken treatment at defaulted and they are now coming back as new patients. So we need to find out, has they ever taken anti-TBs before? We also need to find out the other comorbidities that the patient may be having. This patient could be having other illnesses that even are immunosuppressive, like sugar and diabetes. So we need also to manage the comorbidities as we manage the TB. We also do the nutritional assessment. This is where we do the weight, height, and the BMI or MOT for children. We diagnose the malnutrition, and we are able to manage the malnutrition as we treat also the TB. We also do the patient scans education. This is where we want our patient to understand what TB is. How some they have a lot of questions. How come I got TB? I've not been living with someone with TB. So we need them to understand what TB is, what parts it affects, and how we are making that diagnosis, and also make them understand the duration of treatment and how important it is for them to adhere on the treatment. We also do listing of the contacts of our bacteriologically confirmed patients who are PTB. We want to screen the patient, the contacts of these patients, so that because they have been exposed to TB, we want to find whether they have already developed the disease, or if they have not developed the disease, then we'll need to treat them for latent TB. We also do the screening for mental illness, substance abuse, and alcohol. This will also go a long way in enhancing our treatment through the adherence. We also screen them for post-TB lung disease. This is the effect of the immune response to the mycobacteria, where they will have developed post-TB lung disease even before we diagnose them with TB or during the TB treatment. We also do the linkages of the patients to the other relevant health services that may be needed. So what are the goals of TB treatment? We want to cure the patients and restore the quality of life and their productivity. Bacteriological conversion is not enough. We want them to follow up on their post-TB complications to make sure that they live a quality life even after TB treatment. We also want to prevent death, as we had our death rate as going as 5% as a country. So we need to prevent death from TB. TB is curable. We don't have people to die with TB, but the challenge is that most of the time they come with late diagnosis, and that contributes to our death. We want us to prevent relapse. These are patients who develop TB after they have completed their TB. So either they do not take their treatment effectively, and then after they have completed their treatment, they come back again with TB. We also want to reduce the transmission of TB to others. Once we have put them on treatment, we want to cut the chain of transmission, and also to prevent the development and transmission of drug-resistant TB. So the fundamentals of TB treatment, that is the key things that we look at the TB treatment. Use of a combination of drugs in a regimen. We don't use single molecule. We use a combined drug that are available in fixed drug combination. We usually use at least four effective drugs in the intensive phase. That is where we use the rifampicin, isoniazid, pyrazinamide, and ethambutol. And a continuation phase where we use 2 effective drugs, those are rifampicin and isoniazid. We never use a monotherapy, and never hand a single drug to a failing regimen. Once a patient has failed the regimen, we don't add another drug on top of it. The 2 phases of treatment, as I've said, we have the intensive phase that takes about 2 months, where we use the bactericidal drugs that are able to rapidly clear the rapidly growing bacteria, the mycobacteria. We have the continuation phase that we use the drugs that to sterilize, and that prevents the development of relapse. That takes about 4 to 10 months. 10 months is for the patients who have TB meningitis and TB of the bone. The other TB will take 4 months. Compliance is key in the management of TB. We need to enhance adherence, which we do through DOTS, that's the direct observed therapy. Dosage should always be based on weight. That's why we usually ask the patient they have to have a weight, because their dosage is dependent on their weight bar. Follow-up of response, for those who are PTB bacteriologically confirmed, we do the smears that are done at 2 months, 5 months, and at 6 months. If they convert and the 6th month is negative and another between the 5 and 2 months is negative, that's one we declare it as a cure. And also we do the clinical response, how clinically we do the monthly weighing, and the clinically how are the symptoms. That's how we are able to follow up our patients during our clinic visit. We also do a clinical response for those who are clinically diagnosed. This is the regimen that we use for the drug-sensitive TB. All forms of TB, except the TB meningitis and TB of the bone, we use a 2 months of rifampicin, isoniazid, pyrazinamide, and ethambutol. And we have a continuation phase of 4 months of rifampicin and isoniazid. We also, the TB meningitis and TB of the both the osteoarticular TB, we use with the regimen takes 1 year, that is 2 months of rifampicin, isoniazid, pyrazinamide, and ethambutol, and 10 months of rifampicin and isoniazid. This is the guideline for TB treatment in adults. There is a revised one for TB in children, where we have their stable children going for treatment for 4 months, but that we did not have it covered here. Management of treatment interrupters. We add that we are having an interrupter of the patient who get lost to follow-up as a nation at about 5%. These are the patients who will develop drug resistance. These are the patients who will still continue the transmission of TB in our community. So how do we address this patient who interrupts treatment? We actively trace patients back if they miss a clinic appointment. Call those who already have the drugs, but they're not taking, there are also interrupters we need to enhance their adherence, establish the cause of interruption of treatment, address the problem or concern of the patient. What are the concerns? Why are these patients not able to take their treatment as prescribed? We need to also do the patient education and counseling. So these are the stepwise how now we address the interruption of treatment. If the patient is in the intensive phase, that is between the first 2 months of treatment, if they have interrupted for less than 2 weeks, we just perform the adherence counseling, and then we hand the drugs that they have missed in the intensive phase. If they have missed for more than 2 weeks, that is in the intensive phase, we still do the adherence counseling. For those who are bacteriologically confirmed, we do a smear. If it is positive, we restart the treatment. If it's negative, we continue and add the missed doses to the intensive phase. We also do a drug sensitivity test if the patient has missed more than 2 weeks of treatment. If it is more than 2 months of treatment interruption, we assign an outcome of a loss to follow-up. We return the patient on treatment and restart. The patient who are in the continuation phase, if they have interrupted treatment for less than 1 month, we perform adherence counseling and we continue with the treatment where the patient stopped, and then we had the missed doses. If they are defaulted or are interrupted for more than 1 month, we perform adherence counseling, we do a smear. If it's negative, we continue and add the missed doses. If it is positive, we classify as treatment failure, and we do a DST and we start the patient on treatment. We assign if more than 2 months, we still assign an outcome as loss to follow-up. We register the patient and do a DST and we start on treatment. This is to clarify that not all patients who have interrupted their treatment who are to be restarted on treatment. It will depend on the phase of treatment and how long this patient has missed treatment. Here we are able to do some drug reactions, that's the adverse drug reactions, the few that we encounter. We have the hepatotoxicity. The most likely drug to cause hepatotoxicity is pyrazinamide, followed by rifampicin and isoniazid. So the most hepatotoxic drug is the pyrazinamide. So this is how we classify them: the mild, moderate, and the severe, and the life-threatening. So if ALT is within those values, we have the mild. So in a mild hepatotoxicity, we continue treatment, and patients should be followed up until resolution. That's you continually do the LFTs as the patient continue treatment. If it's moderate, you still continue treatment. Your patient should be followed until resolution or their LFTs return to baseline. But if we have severe, you stop the anti-TBs, the TB drugs, then we'll do the LFTs weekly, and we'll reintroduce after toxicity is resolved. The same with the life-threatening, you stop the anti-TBs, we do weekly LFTs, and then you reintroduce as the toxicity is resolved. These are the hepatotoxicity for the severe and life-threatening. The key thing is here, anti-TB should be reintroduced in serial fashion by adding a new medicine every 3 to 4 days. You don't start them at the same time. The least hepatotoxic drug while monitoring liver function test after each new exposure. You start with the ethambutol, isoniazid, rifampicin, and finally you add pyrazinamide. Consider suspending the most likely offending drug permanently if it is not essential in the regimen. This mostly happens with the pyrazinamide. If you reintroduce it and it is becoming very toxic, it can also be withdrawn. The other common side effect, we have the peripheral neuropathy, that the most culprit is the isoniazid. And that's why we give the pyridoxine to our patients who are on anti-TB treatment. Patients with comorbidities like DM, hypertension, and alcoholism are the most likely to get peripheral neuropathy. However, this condition does not it's not a contraindication to the use of isoniazid. So this is how we manage the mild. This is where we have the sensory alteration. They are mild, they are symptomatic with sensory alteration on exam or minimal paresthesia, causing no or minimal interference with their social and functional activities. The mild one, we just increase the dosage of the pyridoxine from 50 to 100. Then you monitor the symptoms. They usually improve after 2 weeks. If you have moderate, that is where they cause greater than minimal interference with their social and functional activity. You increase the pyridoxine still from 50 to 100 and you monitor. But now if you have a severe form where the paresthesia is causing inability to perform usual social and functional activities, we stop the isoniazid, we still increase the pyridoxine, and then we treat the neuropathy. The same with the severe form of peripheral neuropathy. So for the peripheral neuropathy, that's the severe, the ones that will require treatment, you give nonsteroidal anti-inflammatory drugs, then the tricyclic antidepressants. Carbamazepine is also effective in pain management for the peripheral neuropathy. We have the optic neuritis. This is where they start having visual changes in the visual changes that are not as from the baseline how they were before. In whole, where there is effect on the visual changes, we will stop the ethambutol, which is the most drug that causes the optic neuritis. And then we review for the possible other causes like diabetes, and then we look up for the ophthalmology. This cuts across whether it's mild, moderate, severe, or life-threatening. Thank you.
Yeah. Thank you so much, Agnes, for that presentation. You clarified a lot of issues, the management of TB. So we move to our next presentation, where we'll have Jackson Mugambi, taking us through TB preventive therapy. Yes, please go ahead. Yeah, Jackson, please go ahead. Yeah.
Okay, thank you so much. Okay, now that we've already diagnosed TB, we've treated, but there are those maybe who maybe come into contact with these bacteriologically confirmed cases. We need now to give them tuberculosis preventive therapy, where this is just a treatment that is offered to individuals who are considered at risk of developing active TB. It is also referred to as treatment to latent tuberculosis bacterial infection, and tuberculosis preventive therapy is a critical component for WHO strategy to end TB because it has been effective, ranging from 60 to 90%. Next. Why are we giving TPT? Because it has been noted that nearly more than a third of the world population has latent TB. And this world population, they have a risk of progression to active TB diseases, varying on either age, comorbidity, or immunologic conditions that would maybe they have the risk to. 5 to 10% of these infected with Mycobacterium tuberculosis will develop TB, active TB diseases over the course of their lives. Usually within the first 5 to 10 years of infection, they have the risk of developing active TB. Next. What are these risky factors for latent TB infections that we're talking about? One is high prevalence of TB disease in the population. Then also seropositivity of the cases in the population. It also increases the infectivity of the cases. Then proximity and relation with the infectious cases and environmental factors like poor ventilation or overcrowding. Who are our target population for tuberculosis preventive therapy? People living with HIV, household or identifiable contacts of bacteriologically confirmed pulmonary tuberculosis, prisoners and staff working in prison settings, healthcare workers and other staff in healthcare settings, others, whereby, for example, cancer patient, renal patient, post-organ transplant patient, or hematological patient who have conditions that predispose them to risk of developing active TB. Before we start giving tuberculosis preventive therapy, we have to screen them. We do the screening through symptomatic screening, where it's done before offering the TPT. That is, we need to do the medical history. In the medical history, we want to know the cardinal signs of TB. If they have risk of those, we need to do the physical exam. For example, an active TB disease should be excluded with high level of certainty before initiating TPT to avoid suboptimal treatment of TB or risk the resistance. In our country, we have guidelines for programmatic management of tuberculosis preventive therapy, whereby we have the 3 main regimens that are used in our country. In the guidelines, the first regimen is isoniazid and ivermectin, which is a weekly dose for 3 weeks, is a 12 doses. And indications for these isoniazid and ivermectin are adults, people living with HIV, excluding people who are using protease inhibitors in their ARV regimens, because rifampicin is one of the drugs that reduces the effectiveness of these ARVs. Another indication is all household contacts of bacteriologically confirmed pulmonary tuberculosis patients who are aged above 15 years and they weigh more than 5 kgs. Another is healthcare workers, prisoners, and staff in prison settings. Other adult population at risk, like patients undergoing chemotherapy, they are also under this regimen. The second regimen is rifampicin and isoniazid, which is a daily dose for 3 months. And this one is given to people who are HIV negative children who are aged less than 15 years, who are contacts of bacteriologically confirmed pulmonary tuberculosis. The third one is for 6 months, and this one is given to adults, people living with HIV who are using now the protease inhibitors that we are talking about. And all children who are living with HIV aged below 15 years, or any patient with intolerance or contraindication to rifampicin and rifampicin, isoniazid and rifampicin, and pregnant women. Then we have the contraindications of giving tuberculosis preventive therapy. Before giving these prophylaxis, you need to exclude active TB disease. This is through the symptomatic screening. You also need to check there is no active hepatitis, regardless of transaminase levels. You also need to make sure that the patients that you want to give TPT, they are not active substance abusers or regular alcohol consumptions. Then we also need to check for peripheral neuropathy and contacts of patients with drug-resistant TB, because the drugs that we are using, remember we are using the drugs that are also used in the drug-sensitive TB. So we don't want to expose them again. What are our take-home points from tuberculosis preventive therapy? 1, history of TB and pregnancy are not contraindications of starting tuberculosis preventive therapy. And patient 1, TPT should receive pyridoxine while taking isoniazid-containing treatment. Once weekly for those who are on rifampicin and isoniazid, and daily for those who are taking rifampicin and isoniazid, or those who are taking isoniazid only. And before we initiate tuberculosis preventive therapy, we need to take eligible persons should be subjected to symptom-based screening to rule out active TB disease. Thank you.
Oh, okay. Thank you for that presentation. So we'll move on to our last presentation, which will be given by Mr. Ayabe. He's going to be taking us through post-TB complications. Yeah.
Okay. Thank you and welcome again. I think I will cover this one on behalf of Dr. Wall. We have summarized it. So we want to start by saying that the late diagnosis.
Okay, even as we wait for the presentation to be loaded, maybe we can start with a few questions on the Q&A. Yeah, so maybe the first questions directed to Dr. Anne-Marie. Dr. Anne-Marie, can you hear me? There's a question here about the baby that you presented. So the audience is asking whether the baby received BCG vaccine at birth, or whether they missed this, and maybe this affected whether or not they acquired TB. I don't know whether that history is available.
Yes, sorry, I just skipped for purposes of summarizing, but the child had received BCG. Data on BCG protection varies, with some studies, like one done in Botswana, indicating almost 0% protection. But I think the consensus is that it prevents severe forms of TB. So may be key, for example, in preventing that child from progressing to TBM. Yeah, but will not necessarily protect. against pulmonary tuberculosis. Thank you.
Okay, thank you. So the next question is also directed to you. So someone is asking, would this baby have benefited from a shorter course of treatment to minimize the side effects of the drugs? And then they're also asking about rickets, whether the baby had rickets, and was there any other underlying condition like HIV, which could explain why they got TB?
No, the child was seronegative, and a very young child is actually the one who is at highest risk of progression. This presentation, because there were 6, we are trying to see what we could present. So I focused mostly on making the diagnosis. But if you look at the progression of TB in children after exposure, the greatest progression is in these younger children who are aged less than 1 year. So we failed even in terms of contact tracing, because at least within that household, either the children should have been screened and started on isoniazid preventive therapy immediately and not waiting until the child is being treated for pneumonia. So I think that if they had been diagnosed, for example, during that first episode, that's 6 weeks, depending on the clinical condition, the child maybe did not need oxygen at that point and symptoms were not severe, then they may fit the criteria for the shorter course, which is for non-severe illness. But by the point at which we were making the diagnosis 3 months into symptoms, there's no way this child would have been on a shorter course regimen, because you can already see the burden of disease, and it was difficult even to control it even with a full 6-month regimen. And then the other issues that happened, the immunosuppression from the steroids, the malnutrition, because a child with TB is a baby who is also not gaining weight well, contributed then to the disease course progressing and us needing to restart the anti-TBs. Regarding the other underlying conditions, I think that's a good question in the sense that in this day and age of pneumococcal vaccination, it is not usual to have a child aged under 1 who does not have another underlying lung insult, like for example, prematurity with bronchopulmonary dysplasia, having up to 3 admissions for pneumonia. So if you find that you have admitted a child who was born at a good weight, whose nutritional status is good, mom is breastfeeding, but you admit 1, 2, 3 times, you must ask yourself what is happening. And some of the things are underlying rickets, because that does make children have recurrent infections. And indeed, this baby had recurrent infections, and he did have rickets, which we were treating. I just didn't put that there. They could be having gastroesophageal reflux. They could have cardiac complication, or they could have TB. So my point is, by the time you're coming to number 3, admission for pneumonia in a child, ask yourself what else you're missing. I hope that answers that question. Thank you, Doc.
Yes, thank you. Thank you. That was a good response. So we've managed to get the slides up. So we'll just proceed with the last presentation. It will be brief, then we'll go back to the Q&A. So Bay is here and take us through post-TB complications.
Yeah, thank you so much. I think we are going to just cover the post-TB complications. And we wanted to say that lung health is very important. And that's why we wanted to prevent TB infection in the lungs before, because even after treatment and the delay in diagnosis, we will have a lot of complications, which some of them are life-threatening and some of them are irreversible. And you find that most of our patients who are in the wards, in our specialized ward, are using oxygen just because there was a delay in diagnosis and there was a repeated treatment for TB, which was not TB. So I think we can proceed. Post-TB complications, this refers to the long-term effects following Mycobacterium tuberculosis infection. This infection from the MTP is a very chronic disease, and sometimes when we miss the diagnosis as clinicians, we are causing a lot of effects, and there will be results from immunological response to the MTP infection from those affected organs and tissues. And these effects, if they persist, they will also persist despite successful treatment. It is a long term. Most post-TB complication pattern is from the pulmonary type of TB, and this is what we are going to discuss. But also, we understand that there are also the complications of in the extrapulmonary type of TB. And when we can see here, we can just cover about 5 complications and their management. So the disease, one of the first one is the spontaneous pneumothorax. This is the presence of air in the pleural cavity, resulting in the impairment of oxygenation and ventilation. It is a medical emergency that results from rupture of the TB cavity adjacent to the pleura, and it may be associated with formation of pus in the pleural space That's what we call empyema, leading to pneumothorax. So the presentation is an acute onset of shortness of breath and severe chest pain. That's why we are saying it's a medical emergency. And the management for this one is that the patient should be admitted to hospital for appropriate management. And a chest tube with underwater drainage should be performed. And we give anti-TB treatment immediately because the cause is TB. And then the second one is bronchiectasis. Bronchiectasis is the chronic lung disease, often secondary to an infectious process that results in abnormal and permanent distortion of one or more of the conducting bronchi or the airways. Extrinsic compression of a bronchus by an enlarged node may cause bronchial dilatation, distant with the obstruction, and progressive destruction and fibrosis of the lung, parenchyma, may lead to localized bronchial dilation. And the presentation for this one, bronchiectasis, is a cough. The cough is always in the mornings and it is highly copious. They produce a lot of sputum, and most of our patients who come to us, they come with something like they have the cough just in a vessel or a power, just anakuja na kikombe ama nini na imechayo na kosi. And they are mainly consistent. They are always greenish in color and sometimes blood stains, and they are foul smelling. And these patients may only present with hemoptysis. And these patients are weak and they are sick looking, and the patients are also wasted, and they have difficulties in breathing, and all the time they have reduced activity, and they may not perform most of the activities they have always been performing. And most of the time they have suffered from a chronic pulmonary disease, which was missed even more than even 4 or 5 visits. Now, the treatment for this one is chest physiotherapy, is the mainstay, with postural drainage and other maneuvers to improve drainage of the respiratory secretions. Infective exacerbations require antibiotics, the broad spectrum antibiotics, like amoxicillin and clavulanic acid. They also have to be given some metronidazole or clindamycin for the anaerobic infection. And the pseudomonas antibiotics are like ciprofloxacin, drug generations of cephalosporins should be used when the colonization with pseudomonas is suspected, because the lung is highly, it's not aerated, and most of the infections will set in. Even the normal flora will rise up and cause a lot of problems to our patients. And the same patients will have repeated pneumonias and chest infections. And then massive hemoptysis is one of the positive complications, and they are always seen in capillary disease. And sources include the pulmonary artery, bronchial arteries, intercostal arteries, and other vessels supplying the lung. Tuberculous vascular lesion should include pulmonary or bronchial arthritis and thrombosis, bronchial artery dilatation, and Rasmussen aneurysms. Presentation will be a cough. Patients will be coughing up massive amounts of blood and considered to be life-threatening. When there has been an approximately 150 ml of blood expectorated within 24 hours period, or 100 ml per hour, or associated with airway obstruction, significantly hypoxemic or hypotension. Ensure the airway, blood, and circulation followed, and adequate oxygenation, ventilation, secure the airway with intertracheal tube, position the patient in lateral decubitus position with bleeding side down, give fluids or blood, and give silent to control the bleeding. Refer immediately to bronchoscopy by a physician to make the proper diagnosis. The other complication is a chronic pulmonary aspergillosis. This is as a result of colonization of the tuberculosis cavities or bronchiectatic lesions with the fungal, the fungus Aspergillus fumigatus. The clinical presentation here, there is always a weight loss, chronic productive cough, and recurrent or persistent hemoptysis, and patients who are previously treated for TB. And always they have very light cavities, which means the drugs were not penetrating, and the cavity was colonized by the fungal infection. they always have a fatigue, shortness of breath, and chest pains. And then it is confirmed by high levels of serum-specific immunoglobulin G against the Aspergillus. And then the treatment management here is just antifungals, and antifungals are itraconazole because they are also resistant to fluconazole and the others. And then there is always a role of a surgical resection where the chest physicians and the cardiothoracic specialists will work together. And then the other one is lung fibrosis. This is a sequel of extensive tuberculosis disease with long-term lung tissue injury. Replacement of normal lung parenchyma with collagenous tissue results in changes in the lung, such as thickening and stiffening of the lung walls. Presentation shortness of breath, particular with exertion, chronic dry cough, fatigue, chest pains, and loss of appetite. And this one will always, they will have secretions, and sometimes they may be confused for allergic lung conditions. And the management is long-term oxygen therapy in severe terminal cases. They need to be referred to the chest physicians as soon as possible. And then the last one is the lung abscess. This is the necrosis of the pulmonary parenchyma caused by microbial infection seen in extensive lung damage after tuberculosis. Patients will present with fever, protracted cough, with putrid or sour tasting sputum, night sweats, weight loss, and anemia, chest pains, and hemoptysis. Empiric management is empiric antibiotic given aided by gram stain and culture of the sputum, broad cover for strict anaerobes and facultatively an anaerobic species with any combination of a beta-lactamase inhibitor, e.g. ampicillin, surfactant. And I think that is the end, but the last message is here that we say in celebrating this World TB Day, we say that yes, we can end TB in Kenya and internationally. Thank you.
Okay, thank you, Ayabe, for that presentation. So I think in view of time, we'll just move on to we'll continue with the Q&A. So we'll go back to the first questions, which were, I think, more directed towards the pediatrician. So Dr. Anne-Marie, there's a question here. One of the attendees noted the prolonged use of steroids in the case you presented, and is asking what could be done to reduce to prevent that from happening again in future.
I think just careful review of the treatment sheets, like the way the ones in Kenyatta are currently designed. You indicate treatment for the next, I think, 5 days, and yet you may indicate as if that start date is the day you have renewed that treatment sheet. So it is one, the clinician just sort of being able to review all the treatment sheets, and it comes back to us. And I think we really enjoy rounds where, for example, we're joined by our colleagues who are pharmacists and so on, because then everybody plays a role, because, you know, one person may not have that eye, but I think it just comes back to how you're reviewing, how the documentation is done, and it should be done as clearly as possible by the attending clinician. Was an error on our part. So it was two things. One, the steroids were indicated, but they went on for much longer than we actually thought we had given them. And two, the child's clinical condition was not improving, meaning that there was then still room for us to consider, do we keep this steroid on board? But why is the baby not improving? Is it because of severe disease, which you then treat with the steroids? Because TB treatment does give you a TB iris where there may be worsening of symptoms, or is it that now the steroids have gone on so long that you're causing iatrogenic immunosuppression? So I think there were several things to be considered, and a multidisciplinary team looking at the patient can point those issues out.
Okay, thank you. So there's a question here which are on treatment, which are direct to Agnes. So maybe the rest of the team can also help too, because it's also part of it falls on diagnostics. So the question is it okay to start anti-TBs in a patient based on clinical assessment with a suggestive maybe chest CT scan or chest X-ray, but negative gene expert? I suppose this is asking in the field of adults, because for children already there is a clinical algorithm, but for adults we do things a bit differently. So when is it okay, like, to start anti-TBs based on clinical assessment?
Okay. A negative gene expert or a smear does not rule out TB. So you can always start anti-TBs depending on the clinical presentation of the patient. Then the patient meets all the clinical presentation, and there is also the radiological guide that is either the X-ray or the CT scan that is guiding you that this is likely to be TB. That's why we have clinically diagnosed TB and the bacteriologically confirmed TB, whereby we have like in our country, we account for like 80% are the bacteriologically confirmed, but we have the 20% that are clinically diagnosed. And for us, like in Kenyatta, most of our patients, they are the clinically diagnosed because they're bacteriologically confirmed, they're able to be picked in other facilities. These are patients who are not easy to diagnose. They have to rule out other things before you come to make a decision that this is TB that is clinically diagnosed. But the key thing is, let's always do a sputum first. Let's always try to get a bacteriological confirmation for TB. Even if it is an extrapulmonary, let's try to take that biopsy or wherever the sample for a gene expert or for the destiny, so that you can have a bacteriological confirmation. But if it's negative, does not rule out TB.
Okay, thank you. So I have a question of my own regarding that treatment algorithm that Anne-Marie presented. What is the cutoff for pediatrics? Who uses that algorithm? You know, I think she mentioned children and adolescents. Is there an age cutoff?
15 years.
15 years.
15 years. So 15 years
Yes.
and so we use that algorithm.
Yes.
And I'm asking this because in our hospital, like for KNH, for example, if you go to the adult wards, if you're above the age of 12 years, you're going to land in the adult wards. I don't know. We should we'll keep that in mind. Okay, so the next question, someone is asking about medication, pediatric formulation. So I don't know, how do you give children anti-TBs? Are there syrup or RHZD, or they just crush the tablet and put it in milk or something? I'm not sure what is done for kids.
For the TB treatment in children, we have the rifampicin isoniazid and pyrazinamide tablet, and the ethambutol, which is now as a different tablet, so to make it a drug of 4. So they are currently we have the RHZD and the ethambutol that are dispensable. So we just give the patient, and they put like 5 ml of water, and then the tablet, and it dissolves. So we don't have the struggle of just crushing the drugs, but we don't have the syrups. But for the dispensable, it is very friendly for our children and the flavor.
Okay, so there are dispersible formulations available for children. So there's a clinician from Ongata Rongai who is asking, where can I get the latest TB guidelines? Where are they? Where is their home? Where are they? Online? If you want them, that can be answered by
that is a very important question, but they can just Google the TB management, TB guideline, even on for children, TB and the TB in adults. So if they just Google, they will get the latest version of 2022.
2022.
Yes.
Okay. Yes. So the next
And I want to add that if they come up, especially under the CHS website, the Center for Health Solutions, so they're easy to download from there.
Okay. Okay, thank you. So someone is asking about drug supply, anti-TBs. I think we had an issue at some point. They're saying anti-TBs ran out for nearly a week. So what do you do when such disruptions occur? I don't know if you have probably experienced any thoughts.
Okay, I think we had this issue since last year and some part of this year when the year was starting, when we had a lot of issue with the drug supplies, but currently we have the adequate drug supplies. But during that time, you try as much as possible to connect with the next facility or next sub-county, wherever the mobilization of the drugs from whichever the place, so that we were able to manage our patients not to move out of treatment. But it was a hectic time, but we are off that.
Okay. Okay.
I can just add something, because maybe we did have an opportunity to say that there is a national TB program, an elaborate national TB program that covers all our counties And every county, every sub-county has even a TB, a national TB program coordinator. So if you're even in the private sector or the faith-based institutions, if you have challenges with issues of TB, you can contact the sub-county TB coordinator. And so they can be a source of the guidelines. They can also assist you to make decisions on how to solve a TB related problem. So let's just have that at the back of our mind, and that TB treatment is free, regardless of where the TB has been diagnosed. And I think the reach that we have places throughout the country. Anywhere in any part of the country, you will be near a facility where you can get your anti-TBs. Thank you.
So just to add on for Dr. Njenga, another thing was that when we presented the statistics for TB during the year 2021 to 2023, we saw a very sharp increase in the case finding. So it means that the clinicians and the pharmacists did not work together to project and to put a buffer so that the suppliers can know that there is an increase in the TB cases. So there is also the work between the pharmacists and the clinicians who are having the case findings so that they can project and add an additional request for an additional supply to the suppliers, so that now they are able to project and make it a rough estimate of all the patients to be gathered for.
Okay, thank you for those answers. So the next question back to you again is to IRB, because it's regarding the burden of TB. So you said there was a steep rise in drug-resistant TB around 2020. So they're asking, was this possibly linked to COVID? So it's like, what effect did COVID have on the management of TB? Did we see more drug-resistant TB because people discontinued treatment? Or, yeah.
I think one of the contributions for the rise of TB was the active case finding and the introduction of the gene expert machine, which was able to detect resistance to rifampicin and isoniazid. And the LPA, there is also the something assay, which we are now doing it for our patients, and we are able to pick. And then also the guideline is giving us on how to monitor the cases and go to the community and even screen the family members, and we are able to increase that cases. And another issue maybe was because of the COVID, and most of the patients did not come to the hospital, so some increase could also have been seen from the COVID infection, which was many people were running away because they were getting challenges to come into the hospital.
Okay.
Yeah.
Okay. Thank you. So this one is a comment. Thank you for the well thought out presentations. Great presentation. So here, this is a question about TPT. What is the role of TPT in healthcare workers? They are the healthcare workers. There's an indication for us. You said we are more at risk of getting TB. So should we all be taking TPT? And then how long does it protect you? Because now you'll have multiple exposures because you're always coming back to that hospital. And then, yeah, I think that's basically it. What is the rationale? If you'll have multiple exposures, why should you even take it in the first place? Yeah.
Okay, thank you so much. And healthcare workers, if you look at even our country where we have TB burden, almost more than 80% of our healthcare workers have come into contact with PTB patients who are even not even diagnosed. So if a patient can come and stay in the ward for more than 2 months, then be diagnosed with PTB through bacteriological confirmation, then it means that this patient could have infected most of the healthcare workers in that ward. That is why you're giving them TPT. Then TPT are shown to work up to 10 years. So it can give the protection up to 10 years.
Okay, thank you. So, sorry. Someone is asking about HIV, whether HIV patients get more adverse outcomes compared to the non-HIV patients when it comes to maybe, for example, post-TB complications. I don't know if you have any data or maybe from your experience, you see them faring worse.
Yeah, most of the HIV patients come with a lot of maybe chronic TB disease repeatedly, maybe. And also, a long time when we had HIV infection, we had no ARVs. So most of the relapses, most of the HIV patients were having relapsed with TB because their viral loads were very high. But currently, we are seeing the same scenario between the HIV and the HIV negative. It's the same management because we are having early diagnosis and we are also managing them well. And they start ARVs at an opportune time. So we are not seeing the difference between TB and HIV currently. In fact, even the ones who are HIV negative die more because of comorbidities, but the ones who are HIV positive are taken care of by the HIV and our partners. So we need them to embark on the ones who are HIV negative more than the HIV positive.
Okay. So there's a question about the pediatric regimens. I think someone had mentioned who qualifies for the short course, the pediatric. Do we do the short course? TB treatment regimens for kids. Is that one Agnes or Dr. Anne-Marie? Yeah.
This is something that has been introduced, but like I said, there needs to be criteria for who qualifies for that short course treatment. So already a patient who is presenting in OPD, has oxygen requirements, has severe respiratory distress, is going to go for the normal 6-month treatment. If at the point that you make the diagnosis, maybe based on an abdominal chest X-ray and there was just cough and fever, but the respiratory distress is not marked, then you look at the guidelines and see, is this child fitting into the shorter course? Yeah. So a sick child who we are thinking of hospitalizing, like the one I presented, you would not give the 4-month regimen.
Just a quick addition, a simple way of deciding who qualifies, we can simply say any admitted, any inpatient, a child who is an inpatient diagnosed with TB does not qualify for the short-term regime. But the short-term regime is for essentially for patients who are diagnosed as outpatient, or what you can say essentially stable children who have been diagnosed to have TB. That is a simple way of deciding. But I think the program is in the process of sensitizing the healthcare workers on which children qualify. I think they have been doing some trainings, but maybe they have not reached all the counties. But essentially, it is stable children who are put on that regime, but that excludes any child who is admitted.
Okay.
To add on to what Dr. Jenga has said, you see a child you need to be reviewing every single month, taking the weight, seeing that there's good weight gain, resolution of respiratory symptoms. So it is a child who you're monitoring month on month, yeah? Because that decision can change at any point. And I do feel for children, much as we're introducing these short course regimens, there needs to be caution as you select the patient who is qualifying for that short regimen. Yeah? Thank you.
Yeah, thank you. So I think, unfortunately, we can't take any more questions. Did you have any comments?
But I just wanted to say that for the short-term treatment for children, it has to be a child who is 1 year to 10 years and has no non-severe form of TB. This is a child who is stable, managed as an inpatient, has no danger signs, or that's a patient who is HIV negative. This is a patient who is well nourished and doesn't have malnutrition.
Okay.
That's the one who qualifies for it. So any child who is admitted
is already qualified. Yes. Okay, thank you. So maybe I'll just ask one last question because we've gone over time. We had so much to cover. So this is just for emphasis because we already had a good presentation on TB preventive therapy. So someone is just asking, why can't pregnant women be given 3HP or or 3RH? Just for emphasis, you had already covered it in your presentation. Yeah.
Okay, maybe to respond on that. Pregnant women and breastfeeding women, mostly they are never included in the studies. That is why you don't have a specific reason as to why you don't give them. But they qualify for isoniazid.
Thank you. So I think we are at the end of our presentation. Thank you so much for joining us as we commemorate this World TB Day. And remember our slogan, yes, we can stop TB. Thank you, and we'll see you next time. Thank you to all the presenters for those excellent presentations. They'll be put on the Kenyatta National Hospital website, so you can access the information whenever you want. Okay, thank you. Good day.